A very, very good afternoon, ladies and gentlemen, and thank you once again for joining us in this dissemination webinar. Those who were with us last week will remember that we did what can only be described as introduction to this series of webinars that will take place on a regular basis. The other thing that we did last week was to discuss very broadly and very generally some of the content, including the history behind the formation of the Mental Health Task Force, which culminated in the presentation of our report to the Cabinet Secretary for Health, the Honorable Mutahi Kagwe. The decision was made that we would continue to disseminate and hold what I hope will be open discussion with the interested members of the Kenyan community, literally chapter by chapter. Today, we will be discussing chapter 3 of the task force report in the hope that all of you present, and there are really a lot of people who are joining us this afternoon, will have read the report, and therefore it will not be possible, obviously, for us to go paragraph by paragraph through the report. What we've done today is we have asked two of the members of the task force to prepare a synopsis of chapter 3, each from their own perspective. And as you will see in a moment, both are experts in different fields. The first expert that I would like to present to you is a lady called Charity Muturi. When the task force was formed, it was clear to the members of the task force that we needed representation from users of the services that we are going to be discussing today. And indeed, one of our key recommendations in this report is that really there should be no attempt to formulate law or policy relating to mental health without the participation of those persons that use our services. Charity Muturi was an invaluable member of the team, and Charity, because I may not have said it before in public, your input was and continues to be valued in the extreme, as you represent an extremely important constituency. Among other things that Charity does is that she is the founder of Tunawiri, which is a CBO, the community-based organization that looks after the mental health in prisons. We did visit correctional services, and I'm sure Charity will have one or two things to say about our visit there. Charity is also a global advisory committee on non-communicable diseases alliance. Just so that your appetite can be whet properly, the person who will speak after Charity is somebody I have known for many, many years. Her name is Lynette Ongeri. Her past is not as long as her future. She has already distinguished herself as a scientist, a researcher in mental health, currently discharging her national duty and responsibility at Cambridge, where she continues in the tradition of the very highest possible quality of research. So Lynette Ongeri was of course also a distinguished and very helpful member of the task force, and she will talk to us both as a psychiatrist, as a doctor, and more importantly, perhaps, as, as a researcher. So first, ladies and gentlemen, I give you Charity Moturi, who has 15 minutes to make her point. Charity, your time starts now.
Thank you, Chair, Dr. Njenga. I am very privileged to be here and to contribute in this process. I am very happy that we called for people and they came, and I will be speaking about the burden of mental illness. But my role will be to humanize and simplify it in a way that is easy for the majority of people to understand. And then Dr. Ongeri will, give the facts and figures. And so I'll request for the slides so that we can start. And I look forward to engaging with everyone who is attending. So I'll be speaking about what we felt was the burden of illness. I'll be speaking about what Kenyans said and what the recommendations are. And so when we speak of burden, we chose to look at it in terms of who is affected and to what extent. And we used several indicators, including the number of people suffering, the cost of illness, cost of lost productivity, the cost that it is to the economy, number of deaths, etc. And we especially were concerned that the focus on death as a sole indicator on the burden of illness means that even for persons with lived experience like myself, that we can only be counted as worthy of support if there are enough deaths. And so we said one of the reasons why mental health has lagged behind of other non-communicable diseases is that focus on death. And we would want a change of focus towards looking at general burden at a family level, at a caregiver level, at a national level. And so through this section, you will see reference to psychological burden, physical burden, social burden, and economic burden. And so my hope is that even in the future, we would continue to look at mental illness in a more holistic way. Okay, next slide. So like I mentioned, we chose to take an approach of looking at how this issue affects us at individual level, at the family level. So the caregiver example in this sense is at the level of the family, and then also the community and the country at large. And so we're looking at how exactly does that how exactly does that burden look like at individual level. So just as Dr. Njenga said, I am a person with lived experience and I am a caregiver as well. And so at an individual level, these are things that I go through. Shame, and every time I talk about my experiences, it lifts a little bit, but it's not to say that it's not there. And denial, like personally, I denied for 10 years that I could have a mental condition. And this is something we go through together with other persons with lived experience. So the issue of stigma and discrimination, which varies with the culture and age and so on, but also social inclusion, exclusion. So in many processes of the community, even when you just think of that wedding, there's that uncle that sometimes we really hope, the one who we call a drunkard, we really hope he doesn't show up for a wedding or for a rorasho, because we want that shame excluded. And it also relates to the injustices that we go through, whether it is the violence to the person, whether it is criminalization of symptoms of mental health conditions. We experience the denial of rights, the rights to marriage, the rights to having a family, to owning property, to voting, to aspiring to having political aspirations. There's also the burden of lack of access to basic needs, which translates to issues of housing, issues of not being able to afford good nutrition, not being able to afford, clothing and every other need that someone has. And healthcare is such a big burden for us because currently in the country, good quality healthcare services are very expensive, and that which is more easily available at public level is not at the quality that is, demanded by our constitution, the highest attainable standard of health in terms of accessibility, affordability, and availability. And that becomes a burden on us. The challenges in accessing education, and this is all the way down from kindergarten and primary school, because generally we are looking at mental, neurological, substance use disorders according to WHO, but there are also the disability classifications according to the UN Convention of the Rights of Persons with Disabilities that talks about psychosocial, cognitive, intellectual, developmental disabilities. And so, especially in education, we all know there are special needs schools that are segregated, that are aside, and they serve the purposes of specialization. However, it starts a system of segregation for these children from a young age, which then means that this child, if they need special education, they'll need special employment, they'll need special marriage. We set a standard that excludes them, these children socially. And then economic opportunities as well, because mental illness has an impact on our productivity. And that means there's a challenge in being able to access jobs. And when we access those jobs, keeping them is a challenge if we don't have the right support systems. And all these are burdens to us at an individual level. But it also translates to the people that we are living in. All these things that we go through, our caregivers go through them. But over and above that, it still contributes to dysfunctional families where you find many heads of the home leave, and it leads to a lot of single parent homes because of the burden of the illness and the consequences that are there for the family. Caregivers, especially this time during COVID, are going through so much burnout because, a caregiver already has personal stress, and then now managing the stress of we who are persons of mental conditions. So it's managing stress at two levels. Unfortunately, caregivers are assumed to know what to do. And the systems that we have are very patient-based and do not look at who are the people taking care of this person, what kind of support do they need. So a lot of times we lack guidance, and then we are ignored because our systems, especially when it looks at the issue of disability, we are used to physical disabilities. So being able to quantify or accept a mental illness or the various developmental, intellectual, cognitive, and developmental disabilities is difficult. However, it becomes even more difficult for the caregiver who is representing this person, especially the principal caregivers, because most families have that person who takes most of the burden of care. So that being ignored or not being put at a place that probably you have a child with severe cerebral palsy, you're not able to carry this child everywhere to advocate for their rights. But this parent has that burden on them that causes them to lack even economic opportunities, causes them to lack livelihoods, lack of psychological support, even through our health and other systems. And so this is why we are saying we need to rethink burden. These things that we've mentioned may not have resulted in a death, but there's a burden and it needs to be acknowledged. So I'll request for the next slide to look at what it means then at a community and at a country level. So for all of us, we then have, when this is multiplied across different people, both the persons with lived experience and caregivers as well, then there's an increased burden of suffering that is now sort of put together. Increased burden of illness, increased level of deaths, but also just the general level of happiness. And I'm happy that one of the recommendations that are there are a happiness commission, because then we need to look at, to rethink, burden in a different way, and to be able to see these things actually add up together and affect us as a whole. The other thing is financial burden to the country as a result of having very reactive health systems. So for many of us, we get symptoms of mental health conditions. They are assumed to be a character or a personality issue. They continue to grow, and we only get help when it is very severe. And so that means if it is insurance, for example, then we will use inpatient facilities, and then the average stay is very long, even just for one patient, while the same systems can be provided to have, outpatient care that is more proactive, that is more wellness management than disease management per se. So what we're saying is, as a country, we end up experiencing a big financial burden as a result of our reactive health systems. Another burden is tied to the loss of economic productivity, both for we as persons with lived experience and as caregivers, because caregivers also have to, are left to choose either careers or professions or businesses that are not, that they'll not spend a lot of time in, so that they're able to provide care for either the child or the adult that has a mental condition or a disability based on how severe it is. So this leads to poverty. And while we may not always see that as a burden, it means that there's a loss of output. Because with the right systems, with the right environment, and the right, support systems, then we would be able to contribute better to national development, both as persons with lived experience and as caregivers. And this burden is also the impact of illness the impact of illness should be felt on well-being, happiness, and prosperity, which is what we should be looking towards. And at the end of the day, this burden translates to budgets. It translates to financing, because then more financing is needed to deal with the severity of illness that has come due to the reactiveness of our systems. And that includes also social protection, because then the more severe we are, the more we need the government to provide housing, food, clothing, healthcare, rehabilitation, resettlement, tax relief, both for persons with lived experience and caregivers, and so on. So this is why we are saying that we need to rethink burden, and it may not be structured in the way that I have mentioned it, but you will see it as you read the report. And what we hope is that this will lead to generally rethinking the burden of illness as a country. Next slide, please. So I'd like to get into what Kenyans said, because at the end of the day, the report is a collection of the issues that Kenyans mentioned from the different regions that we went to. And this has guided what we have given as recommendations. So Kenyans said that we have very high levels of depression and suicidal behavior. And this was consistent in the different regions. So it's gotten to a place where the ordinary person is able to see that, no, there's something wrong and something needs to be done. So depression and suicidal behavior was sort of the biggest concern for a lot of Kenyans, but also the high level of mental distress, because many felt, especially in the times where we are close to elections, the climate in the country is so toxic that it leads to mental distress. And this is something that we were happy to hear, because then we can engage politicians and say, you are affecting our climate and we need you to contribute to our wellness, our well-being, and our mental health. Substance use levels were also there was a lot of feedback about the increase in substance use, especially alcoholism, but we also had many people speaking about the increased use of heroin and cat in the coastal region. And in Garissa, there was a huge outcry on the issue of cat use in Garissa. And substance use is something that we need as Kenyans to embrace that this is a disease. It is assumed to be something that those who have lived experience with it or are struggling with it have chosen to have as an illness. But when we do not acknowledge it, we cause it to escalate, we cause it to get worse. And so we are happy that Kenyans were saying we need substance use and substance use disorders to be addressed in the country. We also had from several people the issue of depression and suicide being a special concern or a greater concern when it comes to the age groups of teenage and youth. Because and I remember someone was quoting that it has become normal for teenagers to look at suicide as an option. And this should not be so. And we are happy that it is something that is felt in Kenyans' heart. It's something that Kenyans are speaking about. And we hope that this will be better addressed. Another thing that Kenyans said is that maternal depression is becoming more common. Please remind me, someone. The maternal
postnatal depression. Yeah.
Yes, thank you. So thank you. So in Nairobi, there are women who related this to the increased levels of gender-based violence. And in northern region, we had a lot of women saying that we feel that this issue of female genital mutilation is also contributing to our maternal depression. And we are excited that Kenyans are continually becoming more sensitive, more aware, and more proactive to saying that something needs to be done. And we were able to package this together and say, as a result of this, and as a result of the issues or the figures and the facts that Dr. Ongeri will be getting into, what do we then as a task force recommend? So in the next slide, we look at what we felt that as a result of this thing will help. So one thing is we realized that a lot of the surveys that have been done are either regional or for certain populations, probably because a certain, someone was carrying out a research for a specific group. And so we were saying for us to be able to adequately quantify this burden, we need a national mental health survey that will be countrywide across the country, so that we are able to say that in this region, this is the case, in this region, this is the case, but ultimately for the whole country, this is the definition of burden based on the survey that has been done. We also felt that in order to attract the attention that this issue needs, in order to attract the resources that this issue needs, in order for us as a country to improve our capacity, then it is imperative for us to declare mental health as a national public health emergency, and especially as an emergency of epidemic proportions. And this declaration will then help keep to start that process to attract what it is that we need to be able to deal with this. But at the same time, we said we as a task force have a mandated period for a short mandated period of time. And that means that if we leave the report as it is, then it is very likely that it will go to a shelf somewhere, like many other good reports that we have in this country, including the mental health policy. So we are strongly advocating and proposing the establishment of a mental health and happiness commission, so that what we have put together, what Kenyans have said, what have been recommendations, what people have put in time to do can be actualized. Because this commission would then look at which are the agencies that we need in order to address this. Because we have said that our problem is not just in access to services, but we have a problem with our legal reforms, and the AG's office needs to be involved. We need legislation and so on. We have issues with education. We want our children to grow up knowing that, just like the way they understand HIV and AIDS, that in the curriculum they'll be able to understand, these are mental health issues, and this is the way that they exhibit. and employment, Ministry of Labor and Social Protection, or the private sector, and again, issues of social protection, so that when we say that for those who are severe, we need them to have shelter and their basic needs met, rehabilitation, and there's someone to follow up. So why we need this body is to ensure the actualization of the many good things that have come out of this process. And the other thing that we are saying is that everything that we need to be done will need money. But we are saying that this money should not just be channeled to our health system, but it should have a more wholesome approach, so that we have promotive systems or promotive activities towards prevention. Because like I said, redefining the burden of mental illness also means that we move from just healthcare services to looking at the whole person. We move from disease management to wellness management. And so we are saying this financing should not just be towards the health facilities, but should be promotive, preventive, curative, even for aftercare. Because once we have received treatment, if I go home and I am not able to afford rent, I'm not able to afford food, I'm not able to afford many things, then the chances of relapsing are higher. So I'll keep using NHIF, not because I am not well, but because this economic need that I have is not being met. And so we are saying we need funding for a whole, sort of a wholesome way of being able to deal with it. So we need funding for that. And lastly, the decriminalization of suicide and the decriminalization of mental health systems, which includes petty offenses. So just rightly, as Dr. Njenga has said, we visited Nairobi Remand and Allocation Center. We also visited Mathare Hospital Maximum Security Unit, where I'm very happy to serve every week. And we looked at the brokenness of the system, that in real sense, people, exhibit symptoms. They are either ignored or taken to traditional healers for a long time, or taken to religious leaders for a long time. While this is an illness that requires treatment, it continues to grow. And then either someone, we with mental health conditions are not violent, but sometimes a petty offense will result. Sometimes the suicide attempt will result. But then when they end up in the system, it means we are criminalizing an illness. It's like the way you would now say I'm criminalizing something that that has resulted due to cancer or due to diabetes, and that's not fair. And so we are saying we need to criminalize suicide so that people are able to get the support and the treatment that they need. They're able to get psychosocial support. They're able to get the healthcare support that they need, but also to work with them after. Because we are saying we are not just relevant when we're in the hospital. No, we are relevant in every way, and we need systems within education, within employment, within our hospital systems or our healthcare systems, and not just at Mathare, but at the very clinic and dispensary that is close to us. So these are recommendations that we've made, but what we are saying is that we are not, this process is not done, and we hope that it's just the start. Thank you for everyone who has come in to be able to learn together. Let us now move on to keep the government accountable towards mental health and well-being, towards national happiness and prosperity. Thank you.
Charity, you have exceeded your time, but you have also exceeded our expectations. Well done. It's actually a good thing. If you exceed your time and you go below expectations, then that's a bad thing. But really, I have to say, Charity, that was an excellent summary of the work that you are an integral part in the production of. On behalf of the task force, allow me to thank you most sincerely. I think what we must do with speed is to move on to Dr. Ngeri's presentation, listen to her, and then whatever time will be left, we will hold a conversation about things. But Charity, thank you very much. And Lynette Ongeri, doctor, welcome.
Okay. Thank you very much. Let me just share my screen. I hope it's
Yeah, we
visible
can see
to
it.
all.
Yeah, we can see it clearly. Thank you.
Okay, thank you very much. So Charity has actually elaborated a lot that is in actually my presentation as well. So she gives me an easy task to go through this presentation. Thank you so much, Charity. My topic was on the burden of disease due to mental illness and mental health problems. And she's rightly put, and she's actually elaborated it in a number of times when she says that actually we should not just be focusing on mortality, the number of people who die from mental illnesses. We should be looking at the disability aspect of it, the burden of it from just suffering a mental illness all for a period of time. So that is what my presentation is going to focus on, looking at the burden from the aspect of that disability angle, and also looking at the numbers, how many people are having mental illnesses from a global perspective and also from a national perspective. So, so first we start with why should we even focus? Why should we focus on mental health? So mental health has long been neglected. We are aware of this. Even during the task force meetings, it came up a lot of times. It's been neglected in health, and also it's been neglected in public health practices. It's mental illness and mental health problems. Most of the times they are relegated to the margins, of public health concerns. You'll hear there's a lot this move for malaria, care. Yes, malaria is important, but the burden of mental illness still needs to be considered. You'll hear about mosquito bed nets, for example. You'd hear about a number of public health concerns, but very rarely would you actually hear about mental illness being addressed as a public health concern. So this is why it's important for us to really focus on the burden of mental health in Kenya, burden of mental illnesses in Kenya. Then another issue is also persons with mental disorders have been segregated most of the time. People find that maybe they are different. Others have even argued, do mental disorders really exist? Is this person, are they actually sick, or is it something that they're just putting on? And we've had to really keep telling people mental illnesses are real and they actually cause a heavy set of disability. So yet mental disorders, yes, are significantly disabling, and Charity has already elaborated on at how do we even look at this disability, the impact that someone has. The impact of having a mental illness is very high on a person, on an individual, on a family level, and even on a community level. So those are some of the issues we'll look at. So the world really started paying attention to mental disorders following this global burden of disease. What you can see on your right, there's a study that was published in 1996. It just aggregated 107 diseases. And then because initially we've been focusing on mortality, for the first time using this study, they stopped looking at diseases based on just mortality, like how many people die from, let's say, depression, how many people die from hypertension, for example. Instead, they looked at it from the point of view of the disabling outcomes of specific diseases. So this was like the benchmark at that point, and they called it the global burden of disease included this equation where they're calling it the disability equation. So they use something we call the disability adjusted life years to be able to measure what is this disability that we're talking about when it comes to most of these non-communicable diseases, including mental health. I'll go into more details as to what DALIs are, because nowadays you hear DALIs here, DALIs there. It's important to really understand what that really means. But the key things that they found in this study that this category of illnesses, mental, neurological, and substance use disorders, accounted for 10.5% of all the world disease burden. So meaning that there were very high burden diseases. Mental, neurological, and substance use disorders were found to be very high burden diseases. And 5 of the top 10 causes of disability, which make up more than 25% of years of life lived with a disability for that particular year belong to that category of mental, neurological, and substance use disorders. So a lot of the issues related to mental health problems ended up featuring there because of the disability brought on. So clearly what comes out again and again is that disability is actually the invisible burden. It's not really an aspect of mortality, like how many people are dying. Yes, that is still a burden, but when you would just calculate burden based on mortality and leave out the disability aspect of it, then you've done a complete disservice and you're going to miss the attention that is really needed for people to focus on. So for DALYs, what are DALYs? DALYs are the sum of years. So it's a combination when they add years of life lost because of premature death, and also they combine it with years of life lived with that disability. So specifically for these years of life lived with that disability, they look at how many cases of that specific illness are there. For example, depression, what's the prevalence of depression? How many depression cases do we have? And then they look at the age, at what point do they start this specific illness? At what age does the illness start? They also look at how long does someone experience those symptoms of the illness. For example, does it last just a couple of days? Does it last months? Does it last lifelong? And we all know for a majority of the mental illnesses that they do have a lifelong, a longer duration of disability period, and hence adding on to the burden of disease here. So when one talks about one DALY, what they're actually referring to is one lost year of healthy life. So again, burden of illness, definitely, as Charity put it, must take into account not just mortality, but also the disability aspect of it. There's a figure on your right. I hope you can see it clearly. Here we can see, again, just pictorially trying to explain what DALY is, this disability adjusted life years. And it measures the overall burden of disease expressed as combination of these years lived with their disability and also add on the years of life lost. For a child who is born healthy and they continue on with life, then maybe at some point in their lives, in at an adult life or at whatever point of this human being's life, they get this specific disease or disability and they start living with that disease or disability throughout. And then maybe because of the disease or disability, it ends up causing early death. So for example, in Kenya, our expected life expectancy is about 65 years. So if someone dies before that age, then we know that is premature mortality. So these DALYs are calculated when you focus on the years lived with disability and the years of life lost. So those are really important things to take home, because following that 1990 study, there was also a huge study that was done in 2010 that looked at global burden of diseases, and they looked at a number of diseases, and from that, a number of scientists have been able to calculate specifically for mental, neurological, and substance use disorders, what is the burden of these diseases? What is the burden of these disorders? We found that according to that global burden of disease study, 10.4% of all the global mental, neurological, and substance use disorders accounted for 10.4% of all the global DALYs, meaning that it's mental and neurological disorder. The lost years of lost years of healthy life, and they were all being attributed to mental, neurological, and substance use, 10.4% of them. Then 2.3%, it accounted for mental, neurological, and substance use disorders accounted for 2.3% of these global years of lives lost, 28.5%. So DALYs is a combination of YLL, that is years of life lost, plus years of lives lived with a disability. So 28.5% of global years of life lived with a disability were accounted for by mental and neurological and substance use disorders, hence making them, these mental, neurological, and substance use disorders are actually the leading cause of years lived with disability. Out of all the diseases that they put together, when you put all of them together, you look at mental, neurological, and substance use disorders as a group, you find that they're the ones that are causing the highest level of disability. So DALYs, and then another important aspect that came out from these studies was that these DALYs, these healthy years lost, were peaking in early adulthood for both mental and substance use disorders. Again, this is something that is of crucial importance because as you can see in this figure, the orange or brown, I'm a bit colorblind, are around the ages of the peak for these mental disorders are around the age of 25 years. For neurological disorders, slightly a bit earlier, and for substance use disorders, they're all picking around that mark for between 20 to 29 years. This we know are the most productive years, yet they're the ones that we're seeing that the lost years, the years that people are losing a lot more because of this mental and neurological and substance use disorders. Hence, that's a big concern because when looking at productivity, it means the country's productivity is going to go down if these illnesses are not addressed sufficiently as they should be. Again, back to focus on what Charity talked about, mortality versus looking at the disability. When you previously there was a lot of focus on mortality, and that's why when you look at the red here is speaking about communicable diseases. So 43.7% is talking about 43.7% of years lost, years of life lost, so premature death. But when you look at mental disorders, it was at 0.1%, 1.8% for neurological and substance use. So granted, there's still years of life lost from neurological, mental, and substance use disorders. But when you look at the next pie chart, and examine mental disorders at 18.9%, examine neurological disorders at 5.6%, and substance use disorders 3.9%. That huge chunk, all that chunk is taken up by mental and neurological disorders, meaning they're causing a lot of disability, a lot of time, they start way too early. They cause a lot of disability, or the person suffers from the symptoms for a really prolonged period of time, and they also affect many people. Hence, the years lived with disability are quite high for this mental, neurological, and substance use disorder. And then you look at, again, the red, which is signifying the communicable diseases, it's only 15.5%. Yeah. Then at 5.9%, we have injuries. And we all know also injuries are really highly contributed by substance use problems, and also mental disorders to some extent. Then now the other non-communicable diseases are now fitting into the other section of the pie chart. Again, just to emphasize that it's important to look at mental, neurological, and substance use disorders from the perspective of not only just the years of life lost, but also from the years lived with that disability. If you're going to actually talk about the true burden of mental and neurological and substance use disorders. So how about how big a problem is this in Kenya, and how big a problem is this mental disorders in the world? So we actually, this is actually in our report, and we looked at reports of mental illness in their lifetime. This is the WHO finding that 1 in every 4 has had a mental illness or will have a mental illness in their lifetime. So it means mental illness are extremely common. Yes. And in Kenya, there's a study that was done in Western Kenya in Nandi County by Koba et al. And they found that about more than 50% of the study population of the participants had suffered a mental disorder at one point in their life. So that is 1 in every 2. So really pretty high. Again, when you look at depression rates, also depression is actually the leading cause of this disability in the world, and it's 4.5% of the world population. That was in a study that was done in 2015. A WHO report showed that. And then in Kenya, from that same survey from the Nandi County, 12.6% of the persons within that survey were found to have depression. In that same survey for anxiety, 15.7% were found to have anxiety. Again, depression, anxiety are really high in the world, and they're also just as high in our country. Suicide, WHO reports a global rate of 10.5%, the WHO report for Kenya, they said it's about 5.6, but this study that was done in Kilifi found 4.61. There's one thing about suicide studies that even the WHO always say that we are underreporting suicide. The reason why we underreport suicide is because of the fact that we do not have coordinated system of collecting suicide data in this country. The other reason is that suicide is really stigmatized in our country. So most people will not report it or underreport it because, or misreport it because of the stigma that is associated with it. And of course, there's also another reason that Charity has mentioned is that suicidal attempts are criminalized. Suicidal behavior is criminalized in our country. So hence, it has a bigger ramification if someone says this person actually took their lives, as opposed to maybe they died from another reason. So this 4.61, yes, it's been reported in a survey, but then the other thing is that we have to think about the underreporting aspects. The other issues Charity mentioned was on substance use. Alcohol especially is a really big problem in our country. For the rates, global rates for heavy episodic drinking, that means about more than 6 drinks or 60, they talk about 60 grams of alcohol at one point at one sitting within a period of a month. So, and that 60 grams translates to about 6 drinks in a sitting within a period of a month. That's how we define heavy episodic drinking. And globally, we've seen that 16% of drinkers, people who take alcohol, are heavy episodic drinking, meaning they actually don't need help. It's already an alcohol use disorder. And then in Kenya, a study was done, the STEP survey, and it found 12.6, so almost similar to what global trends are at, and that's pretty high. So again, 12.6, it's almost like 1 in every 10 people have this heavy episodic drinking. So if you think about it, that's a really big number. Then PTSD also is high. The global rates of post-traumatic stress disorder is 3.6%. And then in this study that was done by Koba et al., they found it at 4.5%. So still high rates. When you look at the graph from that specific, pie chart from that specific study, it found anxiety disorders and major depression disorders, as well as substance use disorders, were at the top of the leading types of disorders that are most prevalent in Kenya. Then we had bipolar mood disorder, post-traumatic stress disorder, psychotic disorders, and then other mental disorders as well. So again, that is how the picture looks. And again, just to emphasize that these mental illnesses are actually prevalent in our country and also globally. So what does the burden of disease findings mean? In general, again, I'll just emphasize it's common, they're highly disabling, and they are also associated with significant premature mortality. So mental disorders are the leading cause of disability worldwide, and therefore the mental health must be prioritized by our governments. And prioritization of mental health means our country's resources must actively be targeted for prevention, for treatment, as well as for promotion, just as Charity had mentioned earlier. So again, I'll just brush through this because Charity has already covered this, that majority of Kenyans have been affected directly or indirectly by mental health related problems. In our WHO finding, we saw 1 in every, when you take 4 families, at least one family would have had a person who's gone through, who's had a mental illness at some point in their life. So these are really common things, and they are really, really impacting us. And that came out even in the task force public participation that we had. Depression, suicide was really mentioned, substance use was really mentioned, just as Charity has spoken. And then we found that investments in resources that were geared towards prevention and treatment were either lacking or inadequate in most parts of the country. In this country, the number of psychiatrists, for example, are so few. Not all the counties have a psychiatrist, not all the countries have psychologists put in place. And not just psychologists and psychiatrists, we also have psychiatric nurses. All those mental health providers need to be at least in every part of the country so that we can be able to manage and provide services for people who have mental illness. And not just human resource, we also need the medication, we need the infrastructural kind of support as well. Financial support needs to be thought of in different facets. And then there's also the issue about the prevalence studies. The ones that we looked at, they were not, they were few in number, and they were also localized to small populations. So they may not have been extremely generalized. Our findings may not have been very generalized. So of course, as Charity has pointed out, is that need for declaring a mental health a national public health emergency, just to give it the attention that it deserves, to urgently avail funds for these interventions, and to conduct a national mental health survey so we really understand what's the true prevalence of mental illness in our country. Yeah, thank you so much. People were asking about the link. That is the link, and that is the cover of our report. Thank you very much.
Well, Lynette, you don't disappoint. That was brilliant execution. I think the point that Dr. Ngeri has made very eloquently is the fact that in preparing this report, we were cognizant of the audience that would be reading the report, and deliberately wrote it in a language that we hope is understandable to the majority of the consumers of the report. But as you have seen from Dr. Ngeri, we were faithful to science. We did a lot of research, desktop and desk reviews and so on. So there's a lot of science behind a lot of the recommendations that we make. And I think if requested, particularly for students who are studying in the field of mental health, in particular the burden, I'm sure our secretariat will be able to link up those who are thirsty for more detailed information with ourselves. Now, I have seen two types of comments on the chat and the Q&A. The first set of comments are well done, Charity, well done, Lynette. And another set of comments is when our questions going to be answered, because again, there are very, very many questions being presented to us. I would propose that those who are able to stay on for a few more minutes at the end, maybe extended by 10 minutes, so that we can try and answer as many questions as humanly possible. But those who are unable to stay on, we will understand. Yeah, we'll understand. So I would propose we give ourselves an extra 10 minutes. I know Dr. Njuguna, the Director of Mental Health, and also the head of the Secretariat, is here with us. And before we start receiving any questions, Dr. Njuguna, maybe you have something to say about anything that you've heard from our participants, and then we'll take the questions as will be presented. Dr. Njuguna?
So thank you, Dr. Jenga. Thank you, the panelists and the audience. I don't have much to say. I think our panelists have done it very well. They have put the case for why we should focus on mental illness because of the burden it comes with it. And the burden is not only about the disease. The disease causes very enormous burden at all aspects of life. So I think I'll ask the audience and the public at large that this is a case for mental health, that this is why we need to put resources on mental health, and ask people from all corners of life, we need to focus on this. Back to you, Chair.
Thank you very much. Okay, Alfin, any questions specifically to any member of the panel? Yeah, no questions.
Right, good evening. There are lots of questions.
Yes, go on.
And we'll just start right on with the first question. There's did politicians note or observe that they are most likely to experience mental distress when they lose an election? That's the first one. The second one, how much investment is in the offing in terms of preventive services and respond in regards to availability of professional counseling services, especially in the public health facilities? That will go to Dr. Lynette. Then what should you do when handling suicide cases in therapy? in high school? And is there a protocol of reporting it? Then there's a question that is coming in for the question about the Mental Health Commission. With regards to the mandate, will the Mental Health Commission be duplicating the same work as the Mental Health Board? And is having a commission the main pathway for having the recommendations of the report actualized? I see mental health being a cross-cutting issue that is best mainstreamed in all institutions. Secondly, a review of some policies that are directly related to access to basic services that are critical for mental health.
Stop there. You're asking too many questions. So I'll answer the first one. I'll ask the first, and I will answer the one on mandate, because believe it or not, I'm also part of the panel. So what amazed us, actually, as a task force, I don't speak about myself, I speak as a task force in general, is the extent of the interest expressed by politicians and other leaders. When you read the report, you will see how engaged we were with the respective houses of parliament. The Senate, for example, already has a bill on mental health that is on the floor. And when we engage the Senate Committee on Health, their interest in mental health was palpable. The National Assembly, similarly, I mean, we had members of parliament who expressed a great interest. And in fact, because of COVID, our report was a little bit delayed in being handed over to government. And they are the ones who kept calling for it. And the third thing is that, unknown to some, the BBI itself, which was primarily a political body to advise on politics, has its own recommendation that is similar to ours on the creation of a health and happiness commission type thing. So yes, what the question, I'm avoiding the question perhaps, but there was no specific mention other than like that about the contribution that is made by the politicians every 5 years to the distress of the Kenyans. But that they are interested is absolutely not in doubt. The second question I will quickly answer is about the mandate of our task force. You know, our mandate, strictly speaking, ended when we handed the report back to government. And it's really up to government to decide how to handle our recommendation. And what we're doing here is legitimate part of a task force. But strictly speaking, where government moves with this report is really a decision that only government can make. Remember, the task force was created subsequent to an order by the cabinet on the which came from the position propounded over by the president in June last year. So strictly speaking, we have given our report to the cabinet, and cabinet has the mandate and responsibility of determining whether any or all our reports are presented. There's another question I saw that I could also answer, which was, is there going to be formed one body that will ensure that all these recommendations are put in place? No, no, no. That may not be necessary because some of the recommendations we make are purely administrative, and we have discussed that with the minister and his team, the PS and so on. And the ones that are administrative, those ones are easy to put in place. Others are legislative. For example, the question of suicide being illegal and so on and that sort of thing. And that is quite easy for the National Assembly to take up, repeal that. That can take just a small one afternoon and they can repeal that and so on. Others now, which will take longer, are policy and some might even say constitutional, and those obviously will take a little bit longer. I hope I've answered those questions. Lynette?
Okay, I'll tackle the question on therapy and the child who's in school and they have suicidal problems. How does the teacher address this? Suicidal behavior in school-going children, and this is a therapist in school. who's trying to take care of this child. But one of the things that, suicide is actually one of the things that we say is an emergency. It's a psychiatric emergency. So to the point of maybe this child is actually has had a suicidal attempt, this child needs to be managed in the framework of a facility or a hospital setting, because it's likely they may have even depression, they may have some serious mental illnesses as well. So it's good that they are actually assessed and they are managed, and because there's a lot of care that has to go around there, not just asking of what the problem is and why they are trying to end their lives, but there's a lot more, like trying to see what is there a background illness that this child is also experiencing, and that might need a closer follow-up by a medical specialist. So I would advise that this referral really should take place. It's good that they identify, it's good that they talk to students and to prevent it and to keep supporting the children. But it's also important that children who are in need of care are actually referred for specialized care. In this case, I would say that. So referral is extremely, extremely important for this particular child. There was an issue about counseling services and how can they be, are they available countrywide, and should we be thinking about making them available countrywide? That's actually one in our report, increasing access to counseling services. And I think with this COVID, it's brought, bad things. And I think there's some positive in the sense that the country, the policy, the leaders have seen that there's an importance to counseling. The mental health is impacting mental illness is impacting people so much. People have a lot of psychological distress because of the pandemic. And right now there's even a push to hire more and more psychologists within the government mainstream. So counseling will be a lot more, available, I am sure, because now it's being mainstreamed within the government services. So it is needed, and it's needed in every county, access to counseling. Yeah. I'm not sure. I think Dr. Njenga, you've answered the rest. Is there something I've
I would
missed?
hope so. I mean, Alfin, any other questions? We'll try and answer as many as we can, because I think that's why people come to these webinars. You're muted, so you can't hear the question you're asking us.
My apologies. There's a question. What roles do institutions like NHIF play in unburdening mental health illnesses in Kenya? And in his view, he thinks that NHIF could be covering mental illness, but they could also destigmatize mental illness in Kenya. Well, what's the role of NHIF in unburdening mental health?
Can I go ahead with that, Dr. Njenga?
Yes, go ahead.
Yeah, NHIF and these insurance providers are actually, they do serve a critical role. Charity has just mentioned how there seems to be, if someone is not taken care of well, they're not treated well, they're not managed for their symptoms well, then the chance of relapse is very heavy. One of the issues that affects a lot of us, a lot of people, is being able to afford medication. So you find someone might have NHIF cover in terms of inpatient support. So the NHIF is able to maybe perhaps pay for medication. But then when it comes to outpatient support, then it's really inadequate, and some of the illnesses may not be covered, and it's also inadequate. So the chances of relapse once a person has been discharged end up becoming becoming an issue. So that for sure, in terms of prevention of getting another, episode and another episode of mental illness, NHIF plays a big role by being able to fund outpatient care and fund it very well. Then they would be able to prevent, subsequent episodes of serious mental illnesses. So they do provide us, and NHIF is also the lead when it comes to insurance cover. So when NHIF starts covering this, the other private insurances also take on board and start covering that. So it's extremely important for NHIF to recognize that aspect of investing more of their funds in actually the outpatient care rather than in the just pushing it all for just inpatient kind of service. I don't know, Dr. Njenga, if you want to add or
No,
Charity.
no. I mean, I think even after the publication of the of our task force report, I think we've had engagement with NHIF, and I can say confidently that our cries on behalf of all those brothers and sisters have been heard, and I am satisfied that good days are coming for all those persons who have mental health needs, for cover that is continuous, that covers both in and outpatient. And I think that is one of the points that came out very clearly, that you can't cover inpatients without covering outpatients, because you are guaranteeing a poor service. But I think NHIF is in the process of looking into all these things. And I think these are some of the administrative things that I was kind of mentioning, that also you don't need a new law for NHIF to practice in an appropriate manner. Those are administrative things that originate from the ministry, they go through the institution, and those changes take place appropriately, and I think good days come. So that is the specific answer. Alvin, any other question?
Yeah, to Charity, what are you doing to prevent stigma? And then there's also a question, I think this can go together. Do you have a recommendation to control the number of mentally ill people roaming the markets and trading centers? And then this probably to Dr. Lynette, on the prevalence, there's a question about, are there current reports on the mental health burden in Kenya specifically? And what's the prevalence in terms of the latest data?
Charity, you're muted. Go ahead. Thank you.
Sorry about that. Thank you for those questions.
Very, very briefly, Charity.
On the
We're running
issue
out of time. Yes.
on the issue of stigma, which we had handled quite a bit last week, is one of the best ways of reducing stigma is humanizing the people behind mental illness. When we are able to have positive stories, when someone is able to see that a child with autism has been able to keep a chicken project, or a grandmother with dementia has been able to, do something. So I think we are very key in that, and I'm happy to see very many mental health advocates speaking from personal experience. And I think what I would recommend and request is that organizations in this space would go beyond using our stories to including us in not only ideas or our stories, but developing programs, being able to carry them out to the end, monitoring and evaluation and so on. So I would say right now there are a lot of efforts towards reducing stigma. Most of them are patient-led or led by persons with lived experience, but we need to provide capacity for these people. Let's give them the platforms, but also responsibilities, so that we are able to do more. And the question of people roaming on the streets, it's something that we have delved into quite a bit in the report. And what we are saying is that currently, a lot of people who are on the street in terms of disability, the higher percentages, persons with mental conditions, mostly severe. And what we are recommending is that we would have 2 packages for social protection. So the first being for those with severe disabilities, being able to be provided with housing, clothing, food, shelters that provide for their basic needs, healthcare, rehabilitation, and where possible, resettlement. But we have other mental conditions like myself, which are less severe when it comes to the scales of measurement. And what we are saying is we still need support systems, especially on issues of economic empowerment, tax relief, entrepreneurship training, starting of businesses, and so on. So I think I've answered those 2 questions.
Thank you very much. Lynette?
Okay, on the question on prevalence, prevalence now we're talking about the numbers at that particular time point when they did a survey and they looked at that particular time point, how many people were suffering from mental illnesses. So we have a number of surveys that have been conducted. We have surveys that have been conducted within population or within communities. And those surveys, we find about a 10% prevalence. At that particular time point, about 10% of the persons within that space were having mental illnesses, a specific mental illness. But when you do these surveys within hospital settings, you find about very higher rates, about 25%, even some can go even up to 40%, depending on the cohort of patient groups that you're looking at. So it varies, but the problem we have is that these have been the surveys that we have conducted are maybe in Western Kenya, in Nandi County, for example, in Kisumu County. It's not really representative of the entire country. So we might say it's 10% in Kisumu region, but we're not sure what is happening in Nairobi, for example. We are not sure what's happening in Garissa. Hence the reason why we need representative data. But from the ones that have been done, we have about 10% prevalence rate for mental illnesses. For hospital-based at about 25%. Yeah.
Thank you. Okay, I think that brings us pretty much to the end. Dr. Juguna, there's a question that I would describe as a burning question because it's been asked by a gentleman who submitted a recommendation on the use of technology in the management of bullying in schools. Very briefly, Dr. Juguna, can you tell us how many people presented as memoranda, and to what extent, in your view, as Secretariat, were we faithful to the memoranda that were presented to us from all the sources that we received? Tell the people, because this is their report, how many memoranda we received and that sort of thing, and what we are going to do about use of technology in bullying. Dr. Juguna, very briefly.
Yeah, so thank you, Dr. Jenga. I know the task force received a lot of submissions, both oral and written memoranda across the country, and I know the team was able to analyze this kind of information and put it in various thematic groups. And probably you may not find exactly word by word on what you presented to us, but it may fall within those thematic groups, which we'll be discussing as we move forward. And the issues of mental health in the schools is very specific in this report with very specific recommendations, looking at issues about bullying, cyberbullying, and what can be done. So there was massive kind of submission from the members of the public, I would say more than 2,000, looking at both oral and written submissions. And I can say the team tried to do much justice to try put them in thematic groups and analyze and see what are the key findings and the key recommendations. There's a lot of that information already in our website. There's a lot of more information, more than the report in the website. I would ask the members of the public to visit the Task Force on Mental Health website. It's at mentalhealth.go.ke, and you'll find more information there. Thank you.
There are still hundreds of participants, literally, still with us, but very sadly, one of the things that we must do is to try to the extent possible to keep time. As we said at the very beginning, this is a series of webinars that we are going to do to try and disseminate this, this report in the hope that all Kenyans will have an opportunity of offering an opinion on what it is that is quite rightly their business. So, ladies and gentlemen, I'd like to thank you all. Special thanks go to Charity Moturi and Lynette Ongeri, and Alfrin and the team that has put this whole thing together. Priscilla, very special thanks to you. Dr. Juguna, I thank you all, and all being equal and going according to plan. We will see the hundreds of you who are here today, plus others perhaps, next week at 3 o'clock. Thank you so much, and a very good afternoon and early evening. Thank you and goodbye.